Well, hello, everyone. My name is Sujit Janardhan. I'm a hepatologist at Rush University Medical Center in Chicago, and I'm here at the 6th Annual Liver Connect Conference. And today we're going to be talking about complications of cirrhosis. We're really just going to be talking about the basics. We'll do a quick overview on the guidelines and any of the major updates in 2026. Although most of these guidelines were updated more remotely, there's still a lot of information I think that is important to be talked about. You know, the topics that we're going to be covering include hepatic encephalopathy, ascites, acute on chronic liver failure, varices, and AKI, or acute kidney injury. But I think all of that is encompassed in the concept of cirrhosis and portal hypertension. And so I think a major change in the field has been this concept of redefining compensated advanced chronic liver disease, or CACLD, and then clinically significant portal hypertension. It used to be that we would only focus on cirrhosis with radiographic evidence of cirrhosis or obviously decompensation. And that's still obviously a very, very important clinical finding. But we've started to recognize that there are important clinical changes as a person transitions from simple non-advanced liver disease to compensated advanced chronic liver diseases. And it's, obviously that's a very subtle change, especially in the absence of signs of decompensation. So there's some non-invasive markers that we've been able to use that have helped us identify exactly which patients are at lower or higher risk. And we call it the rule of 5, and that's using transient elastography and platelet count. When your transient elastography KPA value is less than 10, the likelihood of compensated advanced chronic liver disease is very low. That does not mean that those patients don't have any significant liver diseases, especially in the context of diseases like MASH. That can still be associated with significant fibrosis. But in terms of advanced chronic liver disease, where there's a risk for cirrhosis, that's very unlikely with a KPA value of less than 10. Once you get into the 10 to 15 range, there's a possibility of advanced chronic liver diseases. We see now that these are patients that are probably more stage 2, stage 3 fibrosis, and potentially could even have cirrhosis at that point. Once we get above 15, that's where it's probable chronic liver disease, and in some guidance statements, it's likely chronic liver disease. And then advanced CACLD, or compensated advanced chronic liver disease. Once you get above 20, that's definitive compensated advanced chronic liver disease, and anything higher than that. So we couple that with the concept of clinically significant portal hypertension. So once you have compensated advanced chronic liver diseases, especially in those higher KPA values, then you have an increased risk of developing clinically significant portal hypertension. And so traditionally, clinically significant portal hypertension was an HPVG, or hepatic vein portal gradient, of greater than 10. But of course, not everyone is doing these measurements on a routine basis. So we've used, again, elastography and platelet count as a way to determine the likelihood of clinically significant portal hypertension. So once you're in that range of 15 to 20 for an elastography value, that's where you start to, obviously we said that was likely compensated advanced chronic liver disease, or CACLD, but that's where you can say that you have possibly CSPH, or clinically significant portal hypertension. And when your platelet count is less than 110, those two things make it more likely that you might have clinically significant portal hypertension. If your elastography value is greater than 20 and your platelets are any less than 150, then it makes it likely that you have clinically significant portal hypertension. And once your elastography value is over 25 kilopascals, then you likely have clinically significant portal hypertension, even regardless of what your platelet count is. So the reason I went over all of that is because it really focuses on the management moving forward, and that management can affect ascites, encephalopathy, varices, et cetera. And what the guidance now says is that if you have evidence of clinically significant portal hypertension, either by that simple yet complicated elastography layout that we just talked about, or you have clinical evidence of clinically significant portal hypertension, either by imaging or symptomatically, then the recommendation is to start those patients on a non-selective beta blocker. You don't need to look for varices in those patients in order to start a non-selective beta blocker, because we've recognized that starting carvedilol, which is the recommended non-selective beta blocker, not only can reduce portal hypertension, but also decreases the risk of decompensation. So the recommendation is for anyone with clinically significant portal hypertension to start patients on carvedilol at a goal dose of 12.5 milligrams per day, and that can be taken as a single daily dose or twice a day, split into 2 doses. So that gets us to now the management of some of the complications of cirrhosis and portal hypertension. I'll start just kind of picking some highlights from each of them. So for varices, obviously we just talked about the fact that non-selective beta blockers are recommended anytime you have clinically significant portal hypertension. And once a patient is on non-selective beta blockers, the need for endoscopy is not always present. There are Baveno criteria, which are mentioned in the management of portal hypertension-related bleeding guidelines, and that is that if a patient has an elastography value of less than 20 kilopascals, and platelets of less than 150, it's very unlikely that they will have significant significant varices, and so the need for endoscopic screening is not there. But if either of those criteria are not met, either they're KPA values over 20 or the platelets are less than 150, then there is still a possibility and screening might be reasonable. Gets a little gray once you say that, oh, well, they're already on a non-selective beta blocker. Do we need to screen them? The other thing that's interesting, I think, from the relatively recent update on management of varices is the concept of preemptive tips. So it was always thought that when a person comes in with variceal bleeding, we'll treat them endoscopically, especially if it's esophageal varices. And then we just wait and make them prove that they're going to have refractory bleeding before we consider a TIPS shunt. The newer guidelines recognize the fact that preemptive tips may be beneficial in certain populations. So what are the populations that would not necessarily be recommended to have preemptive tips? First, preemptive tips are not recommended in patients as a primary prophylaxis for variceal bleeding. So if they haven't bled at all, it's never a recommendation to proceed with tips for prevention of varices. Of course, there can be other indications for tips. And if a person is had variceal bleed and they're a Child's Pugh A cirrhotic patient, then the benefit of proceeding with the preemptive tips is limited because the risk of rebleeding is lower in those patients. The people that really should be considered for preemptive tips are people who are Child's Pugh C with a Child's Pugh score of 10 to 13, and Child's Pugh B with a score of 8 or higher. So those are the people that should be considered for preemptive tips. And the reason for that is because the risk of rebleeding in those patients is quite high. There's also been guidances on tips in general in terms of the criteria that we should be using to make a patient eligible or not eligible for tips. And I think it's important to remember that although, a long time ago, there was the Mayo score for end-stage liver disease, the study from that demonstrated that a MELD score above 18 increased your risk of tips-related complication and mortality. The current AASLD guidelines, at least this is in regards to tips, does not specify a specific MELD value after which TIPS is contraindicated. So I think this is really where we have to use our own judgment and say that if the risk of this patient dying from their complications of liver disease, whether that's rebleeding, refractory ascites, etc., is higher or outweighs the risk of potential complication with TIPS, then we just have to weigh that balance and do what's best for our patients. There has been a relatively recent update for the guidelines on acute on chronic liver failure. I think the biggest thing that we gained from this update was a nice clear definition of what exactly acute on chronic liver failure was. So it requires the presence of chronic liver disease. Now, that can be chronic liver disease, that can be compensated cirrhosis, or that can be decompensated cirrhosis. But then you need to have some type of acute event, whether that's GI bleeding or infection, et cetera. And very often that sets off a really brisk systemic inflammatory response syndrome. And that is really what mediates the acute on chronic liver failure. And when you can treat the underlying cause, sometimes you can get early reversibility, but often when you don't, you can progress to acute on chronic liver failure, which is often liver failure defined by elevated bilirubin and coagulopathy in the form of an elevated INR. As well as a secondary organ that starts to fail. So that could be acute kidney injury, that could be cardiovascular collapse. Another organ other than just pure liver failure. So that's how we used to define acute on chronic liver failure. And even once you've reached that point, there is a reversibility that's possible. But some patients will continue to progress, and unfortunately, that's when patients either need to be considered for palliative care or hospice if they don't have other options, or for a select group of patients, consider liver transplantation. The guidelines do kind of go through what the highest risk for transplantations are, or what the risk factors are for transplantations in the context of acute on chronic liver failure. I don't want to go through all of them at this time because it's too long, but I would recommend to refer you to the guidelines to look to see what are the factors that are not absolute contraindications to transplant, but that can influence post-transplant outcomes. One important point that's probably critical in terms of determining prognosis for your patients with acute on chronic liver failure is the scoring systems that are used. So NASELD or the CLIF ACLF score. And using scoring systems such as those can help you define what grade of ACLF you have, whether it's grade 1, 2, 3, or 4, and that helps us determine prognosis. So patients with grade 4 ACLF, their prognosis is poor, and those might not be patients that you would want to proceed with liver transplant because the outcomes are so high, or the outcomes are poor. Getting to the next topic of AKI, I think that our management of AKI in cirrhosis was majorly changed with the ability for us to now in the U.S. have access to terlipressin for treating type 1 hepatorenal syndrome, or what we now call HRS-AKI. But I think in the context of acute on chronic liver failure, we're starting to see that not all AKI in cirrhosis, and this is something that we've already known, but it is even more highlighted by the fact that not all AKI in cirrhosis is due to hepatorenal syndrome, especially in the context of acute on chronic liver failure. And where I'm seeing this is in our patients with acute on chronic alcoholic liver disease that present with alcoholic hepatitis. Very often, those patients don't have the hemodynamics that you would expect with hepatorenal syndrome. Sometimes they don't have ascites, which of course is a critical component of having the physiology that dictates hepatorenal syndrome. So it's important that the AKI in patients such as those might not be HRS-AKI, but rather non-HRS-AKI that's caused by acute on chronic liver failure. And in that context, it's not the splanchnic vasodilation causing renal hypoperfusion due to decreased effective arterial blood volume that drives the AKI, but rather the massive inflammatory response, as we mentioned, the SIRS response, that can drive end organ damage, including AKI. And there are prognostic markers that are in development, and some of which are already available to help you determine whether it's non-HRS-AKI versus HRS-AKI. But I think honestly, just looking at the patient's physiology is helpful. If you have a patient, hypotension, for example, is not in the diagnostic criteria for hepatorenal syndrome. But if you have a patient that is coming in with, let's say, what looks like acute on chronic alcoholic liver disease with a acute alcoholic hepatitis superimposed on chronic alcoholic cirrhosis. And they come in with bilirubin that's very, very high, let's say in the 20s or 30s, so they're at very high risk for bile acid nephropathy. And their blood pressure is 120 over 80, right? So a MAP score that's relatively high. That is a person that is more likely to be non-HRS AKI as opposed to HRS AKI. In contrast, if it's a person with MASH, that's had persistent chronic liver disease, there was no acute event that caused them to get sicker, but they just have had, refractory ascites that's requiring paracentesis every week, and they come in and they have a progressively rising kidney injury, and you've done all of the things to rule out alternative causes, and their blood pressures are low with MAPs in the 50s or lower 60s. That's a person that's particularly at risk for HRS AKI, because that is the type of physiology where you would expect massive splanchnic vasodilation that causes decreased effective arterial blood volume and diminished renal perfusion. So I think in the context of, so much alcoholic liver diseases that we're seeing in our transplant centers these days, and not just in our transplant centers, but in our community hospitals, it's really important that we properly identify the patients that have acute on chronic liver failure related AKI that's not driven by hemodynamics, but rather inflammation, versus true HRS AKI that's driven by hemodynamics. And the reason that's so important is that the therapies for hepatorenal syndrome are meant to treat the hemodynamics of HRS physiology. They're not meant to treat the inflammatory response that we see with acute on chronic liver failure. The traditional management of hepatic encephalopathy is a combination of lactulose, or an acidifying laxative, along with rifaximin, so a non-absorbable antibiotic. And the thought there was that we have acidification of the colon, we have clearance of the GI tract from a lot of the toxins that get transmitted through the portal circulation and then get systemically shunted to cause encephalopathy, as well as a change in the microbiome using rifaximin to a more favorable microbiome that doesn't cause as much encephalopathy. But there are some patients that will have difficulty with constipation, and no matter how much lactulose you give them, they're not having bowel movements, but they get tons of small bowel gas and they get really bloated. I think those are the patients where we might want to consider polyethylene glycol, 3350, sold commercially as Miralax, but obviously lots of generic versions of that. What we found in our center is the use of polyethylene glycol in place of lactulose when patients are in that situation where they're giving more lactulose but not having bowel movements has helped to facilitate bowel movements and resolve hepatic encephalopathy. So very often we use a combination of lactulose as well as polyethylene glycol to both facilitate the acidification of the colon, but as well as allow for adequate bowel movements to treat the hepatic encephalopathy. So the current ACLF guidelines do mention the use of both lactulose as well as polyethylene glycol to help manage. Obviously, one of the things that's not on this list of things that we were supposed to mention is something that's near and dear to my heart, which is nutrition and sarcopenia. One of the things that we've known for a very long time is that sarcopenia is a precipitant of almost all of the complications of cirrhosis that I've talked about, other than variceal bleeding, but ascites, hepatic encephalopathy, and just overall liver decompensation is greatly increased by sarcopenia and malnutrition. So making sure our patients are getting adequate high-protein diets, as well as really combining that with, as possible, exercise and strength training to help maintain muscle mass is really a critical, important point. Finally, there are some new technologies for the management of ascites. So traditionally, ascites has always been managed with diuretic therapy, and once they develop diuretic resistant or diuretic refractory ascites, proceeding on to either a TIPS shunt or large volume paracentesis. Large volume paracentesis is obviously complicated by progressive malnutrition malnutrition and sarcopenia. So TIPS shunt, when possible, probably offers a significant survival advantage. The data in the comparative trials is marginal, but I think that in practice we see our patients decline very quickly when they're getting large volume paracentesis coupled with all the other catabolic effects of cirrhosis. This is another situation where TIPS shunt is, we have to weigh the risk of not doing a TIPS and having large volume paracentesis and progressive sarcopenia against the risk of doing a TIPS shunt. So what we've found is that sometimes moving toward TIPS a little bit sooner is beneficial, because as patients get more sarcopenia, their hepatic encephalopathy worsens, and then TIPS becomes a contraindication because they have, uncontrolled hepatic encephalopathy that's exacerbated by their sarcopenia. There's also now newer company technologies available, such as the alpha pump, that can also help with ascites management, that we're seeing more and more adoption of that. All right, so overall, that is my extremely short review of the guidelines and updates in complications of cirrhosis, including ascites, hepatic encephalopathy, acute on chronic liver failure, varices, AKI, and the extra bonus, which was sarcopenia. This has been a great meeting, and we hope that you can join us next year.